Good morning. I'm Tricia Carino. I'm chair of the lectures committee, and I'd like to welcome everyone to our online town hall on COVID ID. We're going to start off the morning with two speakers who I'll introduce in just a second. And the second half of the program, Meg Taylor will be leading a panel discussion, and she'll introduce her panel members when the time comes later on this morning. I'd first like to introduce Dr. Hank Weiss. Dr. Weiss is an epidemiologist whose career has focused on injury prevention, infectious diseases, and opioid harm reduction. He's worked for many years with a range of public health issues in various settings, and he works at the intersection of science and policy. He brings a practical understanding of what public health practitioners face in the real world. The second speaker is Brittany Grogan. And Brittany is a public health analyst with Madison and Dane County, an organization I've heard a lot about the last couple of weeks. Prior to COVID, she was heavily involved working with data, managing it, quality improvement, analysis, interpretation, presentation, and the visualization of data. In addition to public health, she's also worked pretty extensively with violence prevention. After finishing graduate school, Brittany worked for a few years with the Wisconsin Department of Health Services, but for the last 2 years, she's been with Public Health Madison and Dane County. And our third speaker who will be leading our panel discussion is Meg Taylor. Meg is a nurse who spent most of her career working in public health. She has served as the executive leader of the State of Wisconsin Public Health Agency and has served as a public health consultant for the states of Wisconsin and Washington. Meg has also served as a site visitor for the National Public Health Accreditation Board. And with that, I'd like to turn the presentation over to Dr. Weiss.
Good morning, everybody. Glad you all can make it. Looks like we're up to almost 60 participants. It's a great turnout on a very wet Thursday morning. I sincerely hope you all had a wonderful summer in these crazy times. Perhaps a few of you were somehow able to find yourself on a cruise and came back looking like this couple. Or perhaps you weren't so lucky with your cruise and you ended up on the Titanic. You survived, but you had to listen to complaints like this coming from some of the passengers on the starboard side of the boat. Well, it's good to start out with a little humor, but of course this is a very serious and deadly topic. To remind us of that, I'd like to dedicate this presentation to the 1,150 US health workers who have died from COVID-19 so far, and the millions of health and public health workers who remain on the front line fighting this pandemic. The fallen have paid the ultimate price for trying to keep many of us as safe and healthy as possible. Of course, it wasn't their intention to make this sacrifice, but that doesn't diminish our gratitude, respect, and thanks that they and their colleagues were there at the time of their calling. It's a lesson I think we all can learn. To the 1,150 US health workers, to the 190,000 other US victims, to the 1 million other deaths across the globe who have succumbed to the disease, and the millions likely to follow. I think we should dedicate not just our gratitude, but our present and future actions to ensure that the next time, as a global community, we're more prepared to deal with such a devastating threat like that of COVID-19. We know many more of them are on the horizon. Well, for those that didn't take the cruise, I'm sure most of you have been staying home the last 6 months and you're adjusting to the disturbing and frightful realities of a global pandemic and wondered how we got here, what we know, what we don't know, and where is it all headed. And if that describes your current frame of mind, you've come to the right place, because that's pretty much what we're going to cover for the next hour. So we're going to start off with a little bit of how we got here, what we know, get into some of the epidemiology and national, state, and local numbers. We'll talk briefly about testing and treatments, get into vaccines a little bit, talk about non-pharmaceutical prevention and control, and then spend a little time talking about how I stay informed through the pandemic and make recommendations how you should stay informed, and then some summary conclusions. Hopefully close to 11 o'clock, the talks will be over and we'll switch over to an expert panel. Throughout today's town hall, we'll be using Slido for questions and answers. You got instructions in the email on how to use it. I'll go through that briefly. And then if you'd stick around just at the end, I've got a 30-second evaluation I'd like to have you go through and do the survey. So before we dive into the content, I want to go over how you should ask questions today using this online administrative tool called Slido on your smartphone. And we're going to use the same tool to conduct a little icebreaker in just a minute. Again, we're going to hold off and having you ask questions today directly to us, but you can ask them in the Slido panel on your smartphone at any time, and we'll get to them when the panel comes on board. So you all got those instructions. Urge you to get in there now, log in at Plato. Don't worry if you don't get in, if it's not working right, if you can't figure it out. As long as enough people do, we'll get the interaction desired. So the first thing that you should see after you join the event is the Q&A section tab. And that's where you type in any question at any time for any of the speakers or later in the town hall to the expert panelists. You're encouraged to use your own real name, but it is not required if you are shy. That's one of the benefits of using this tool. What's great about Slido is with a large audience like we have today, we can't possibly answer all the questions. And so this gives us a means to prioritize the questions that we can utilize and answer together as a group. That way we can see which ones are the most popular, and we'll try to get to those first. So use the Q&A tab in Slido to jot down your questions and upvote like the ones you wish to prioritize. The Q&A tab will always display whenever we're not polling, which I'm going to describe next. The other interactive part of Slido we're going to jump into right now is the polling and quiz features. Slido will automatically switch to the poll tab after I activate some questions for you in a few seconds, and the results will be displayed in real time on the interactive Slido wall in the Zoom window. I think it also shows up on your phone. The first three polls are very short word cloud questions designed to elicit feelings and emotions about how the pandemic has affected you and your family. And the second two are designed to quantify how much the virus has impacted our community, the community in this town hall. These are all anonymous, so your answers are not connected to your name. Feel free to say whatever you want to say anonymously. The last part of the polling, after the first 5 questions, will be a 10-question graded COVID informational quiz. And we're going to have the two highest scores in that will receive a prize mask lovingly made by our own Meg Taylor. The quiz asks for a name. You can put in your real name if you want a chance to win the prize. You can just put in a pseudonym if you wish to remain private. So let's get started on the polls and quizzes. If you get confused or lost again, don't worry about it. We'll return to the presentations in a couple of minutes. So just try your best. So I'm going to switch over to Slido. And I'm going to start the first poll. So you notice your smartphone has switched. And this is where we want 1 or 2 or 3 entries, single words of, in a word, what do you most look forward to doing when the pandemic emergency is over? So go ahead and enter a word. And then after you enter one, if you want to enter 1 or 2 more, go ahead. And what we're going to start see coming up is the word cloud. So the words that are the most popular are going to show up bold in the center. Great, everybody's getting it. Got about 11 responses so far. You can tell this is a senior audience mostly. Travel's really big. And of course, we want to hug our grandkids. Got about 15 responses. I'll give it a few more seconds. Wait till we get 20 responses maybe. Great, that was easy. All right, so that's what is the most popular in that word cloud. So let's go to the next poll. A similar word cloud question. In a word, how have the last 6 months made you feel about the government and society? 1 to 3 single words are okay. Again, this is anonymous. Go ahead and enter. Dysfunctional, failure. I don't see too many positive reactions about our government. Is there any positive? Nope, not yet. Mixed feelings. We'll have to count that as a positive this morning. Now, I suspect we might get different answers if we did this poll in some other region, and we'll actually be talking about that later in the presentation. Great, we got 23 quick responses. People are getting a hang of it. Fauci rocks, there's a good one. A lot of D's: disgusting, depressed, disappointed, disorganized, dysfunctional. And I'm afraid that's how many of us feel. All right, let's go to the next question. This is our last word cloud. In a word, how have the last 6 months made you feel about yourself and your family? Again, this is anonymous, so feel free to be honest. There's a positive response. Thank you for that. Several of you did that. Very interesting when you compare the question about government, compare the question about yourself. Very, very much more positive responses here. Yeah, we certainly are. Most of us are very lucky to be trapped in our homes with retirement income and nice homes to be in. That's not true for everybody, of course. Great, 25 responses on that. All right, let's go to the next one. So this is the more quantitative polling, just to have you let us know personally how many people you know who have tested positive for COVID-19. None, 1 to 2, 3 to 5, 6 or greater. So out of, we'll let this one go till we get closer to 30 or more. So about a third of the group knows no one. Not too surprising, especially considering probably the socioeconomic makeup of most of the people on this town hall. Another third, none, and then a few 3 to 5 or 6 or greater. Myself, I'm pretty sure our neighbor had it, and my brother caught it very early in the epidemic in March, coming back from a ski trip in Colorado, back to California. He's recovered well. He was fine, but his wife was pretty sick for a while. Okay, we got one more question. How many people do you personally know who have been seriously ill or died from COVID? So the other one was how many people were sick, but how many people were seriously ill or died? And not surprisingly, very few of us actually know somebody who has been seriously ill or died. Again, if you're in a different socioeconomic group, different racial group, these answers would be very different, and we'll talk about that a little later in the lecture. 17%, 1 to 2, looks like 1 or 2, new 3 or 5. This is not going to get better, of course, as the epidemic continues to spread, and we'll talk about some of the numbers and what we might expect. And I think we have one, well, we'll do the quiz later, so don't answer that, don't join that. We're going to flip back to the presentation. And we'll do, oh, I'm sorry, we are going to do the quiz now. So let me go back there. So put your name in on the quizzes. This is not anonymous. We will know who answers the most questions. You don't have to put your name in, or you can put a pseudonym in, I think, to just go ahead and answer the 10 quiz questions that we're going to do. So I'll wait till more people get their name in. I know we've got at least 30 people on the line, so we'll wait till more people get in. You want a chance to win one of those great masks. I think we're going to have 2 masks available. Is that right, Meg?
That's correct.
Great. Okay, let's start the 10-question quiz. What does COVID-19 stand for? Once we hit about 30 responses, we'll go ahead and see what the results are for each question. All right, time's just about up. We'll see the answers. So most of you said it's the term that stands for coronavirus disease 2019, the year that it was first identified. And the right answer was that one. So 80% got that one. The next question. What other viruses belong to the coronavirus family? Let's get the answers in quick. Everybody's getting the hang of it. We're almost up to 30. You don't get it in time, you'll get a 0 for that question. But it's a pass-fail system, so everybody will pass. And most people chose SARS and MERS, and the right answer was SARS and MERS. Good, we've got an intelligent audience here. The next question. A vaccine stimulates your immune system to produce antibodies similar to the way it would if you were exposed to the virus itself. True or false? And almost everybody got that right. Yep, it does. Next question. There are currently vaccines for the following coronaviruses. I should say these are vaccines that are in distribution. There are experimental ones for some of these. Meg, I think we might have a lot of people at the top of the leaderboard when we're done. We have to randomly draw for those 2 masks, unless you want to make 10 more.
I like the random draw idea.
This separated some of the people. Some had none of the above, and some said SARS and MERS. The right answer was none of the above. Question number 5, about how many vaccine candidates for COVID-19 have been proposed for development? Timing is going to be more important here. We want to get through the quiz and to some of the presentations. All right, here we go. Some said, a lot said 25, some said 120, and it's 120 plus. Huge number. So maybe you're not going to have to do a drawing, Meg. 6th question, where was the first known death due to COVID-19 in the US? Washington State, California, New York, or Oregon? This is a hard one. Most people said Washington State, and you know, that's what I thought originally too, but it was actually in California. Who was the first governor to close schools in response to the pandemic? Governor of New York, Maryland, Ohio, or California? It's great, people getting responses in quick. As soon as we hit the first 30, I think we'll go to the answers. Andrew Cuomo in New York was very popular. So was Gavin Newsom in California. However, Mike DeWine in Ohio was the first governor to do so. And 3 more. The virus is mutating rapidly. True or false? Most said no, and that's correct. It is mutating, but not significantly, functionally speaking, at the time. And next to last, currently, which group has had more severe effects from COVID-19, men or women? This has been widely publicized. Most people should get this one right. And we got most of the responses back. Almost everybody got it right. It's indeed men, and we'll see some of the figures. And our last question, true or false? COVID-19 has currently been detected on all 7 continents in the world. This one is a little bit of a tricky one. And a lot of people said true, but it's false. It has not yet been detected in Antarctica. And I checked that within a week. There haven't been any cases there, but of course, very few people there are there, and we don't know whether penguins are susceptible. So here we go. There's your winner. We have a clear winner. We have a winner and a tie, Meg. So you're going to have to flip a coin between Bob and Robin to see who gets the second one. So you got the names down, Meg?
Not quite.
Thank you, everybody, for participating in that. Hope you enjoyed it. It was meant to be both fun and informative.
I have the names.
Okay, thank you. So let's turn the quizzes off. go back to the presentation. There we go, got that little thing off the screen. All right, so we're back to the lecture here. How we got here. I'm not going to really go over this very quickly because of our limited time this morning, but think back to early January when some of these very first few science and media publications started coming out with information about the novel pneumonia cases coming out of the Wuhan market. So much has changed since then, and we've learned so much. But it seems both like a very short time and a very long time ago that we first heard about this. Now it's it's really too early to, I think, write the definitive history of how we got into this mess and how everything started and how things came together and who did what and what worked and what didn't. But one of the best histories to date I would recommend everybody look at is How the Pandemic Defeated America by Ed Young in The Atlantic. He talked about how it came to it, how a virus 1,000 times smaller than a dust mote humbled and humiliated the planet's most powerful nation. Ed is one of the more powerful writers of the pandemic. I've come to really appreciate his style, his hard work, and the detail that he gets into in his articles. So rather than me talk too long about how we got where we are in some of the history, I'm going to refer you to look at Ed's article. He also just came out with another one yesterday, which also is a superior piece of journalism about how America is trapped in a pandemic spiral. And again, you can get that in The Atlantic. But let me just read something from his How the Pandemic Defeated America. COVID-19 is an assault on America's body and a referendum on the ideas that animate its culture. Recovery is possible, but it demands radical introspection. America would be wise to help reverse the ruination of the natural world, a process that continues to shunt animal diseases into human bodies. It should strive to prevent sicknesses instead of profiting from it. It should build a healthcare system that prizes resilience over brittle efficiency and an information system that favors light over heat. It should rebuild its international alliances, its social net, and its trust in empiricism. It should address the health inequities that flow from its history. Not least, it should elect leaders with sound judgment, high character, and respect for science, logic, and reason. So again, I'm not going to go much further into that topic, but refer you to Ed and some of the other fine writers that are covering the topic. So the next thing is what we know and don't know about the virus. And from a virology standpoint and from an epidemiology standpoint, it's an amazing virus. And it's a puzzling virus. In fact, some have called it the paradox virus because of all the very strange dualities that it brings with it. It seems to be a virulent pathogen with a case fatality rate a little under 1%, but it's also characterized by a huge percentage of asymptomatic carriers and pre-symptomatic spread. There is a tremendous variation in the infectiousness. A lot of people don't get sick at all, but a lot of people get very sick. Some can transfer it very easily, some probably not so easily. And it probably has to do a lot with the setting in which the transmission takes place, in addition to the host and how the virus acts within the host. And then it's a pandemic pathogen that fortunately, mostly, but not entirely, skips children, but not when the resurgence is driven by school openings. So children don't get sick, but they can spread it and are important in some of the community spread that occurs. In terms of mortality, most of us know that it's very, very devastating to the elderly, but it mostly spares the young. And this is, if you are familiar with statistics, you recognize the exponential curve here. It's not just additively worse in the older. it's exponentially worse in the older age groups. And that's one of the reasons why Plato is being very conservative, like other senior groups ought to be on reopening. This is normalized death rates by age group for different counties, normalized by the age population pattern in each of those countries. And it follows a very similar pattern once it's normalized. We also find that US minorities are very disproportionately impacted with the deaths per 100,000 people for Black or African Americans, almost twice, well, more than twice that of whites, and also a big impact in the Hispanic and the American Indian communities. In fact, we have lost over 37,207 Black lives to COVID-19. One, get this and think about it, 1 in every 1,125 Black Americans has died from the disease so far. This is not a virus that is an equal opportunity employer. In addition to the deaths, it can be a nasty virus in non-fatal cases. Some of the recent information compiled by CDC, recently published in the Morbidity and Mortality Weekly Report, showed by age group how previously healthy people are not back to work within 14 or 21 days after testing positive. Now it goes up quickly in the over age 50, but it's a significant percentage of the people that are still too sick to work 21 days post test results. And you've heard recently about some of the long haulers, people that have sequelae of the disease lasting weeks and months afterwards. And we're still beginning to define those people and what they're suffering from. And one of the reasons why people are suffering from so many different symptoms weeks and months after is that the SARS-CoV-2 is not just a respiratory virus. It's not just a respiratory disease, because the virus itself has an affinity for something called ACE2 receptors on various cell types. It actually causes damage across numerous human systems. So that includes the nose and the lung as a respiratory disease, but it also includes the gut. That's why people often have diarrhea. It includes the endothelial cells that in blood vessels, which is why it's often a blood vessel disease leading to clots and other problems. It can impact on the cardiac cells, and that's why people often have heart problems. And it can impact on some of the CNS systems, which is why people sometimes lose their sense of taste and smell. So an important take home is that it's not just a respiratory disease. It can impact on many organ systems. We're learning more about kids. We have a lot more to learn. We have established very clearly, thankfully, that deaths among children and teens are low, but they're not invulnerable. If they do get sick, 1 in 3 children hospitalized do end up in intensive care, and that affects mainly the children that are under 2 years of age. A very small proportion of children infected with COVID-19 get a condition where multiple organs come under attack from their own immune system. You might have heard of this. It's called MIS-C, multi-system inflammatory syndrome, similar to Kawasaki's disease. Again, very rare, but as it strikes a large number of kids, we do see this, and it's very clear that COVID-19 is responsible for the upswing in those. Well, how do you catch this disease? Mainly, it's the closer you are to someone infectious and unprotected. And the longer you are in contact with somebody who is infectious and there's no protection between you, the more likely you are to contract it. That means you're susceptible to getting it from household contacts. It means that indoors is much worse than outdoors, particularly in rooms without sufficient ventilation. We've seen outbreaks in which loud talking, singing, Screaming expels more virus and thus increases your risks. And then you have bars and gyms and crowded restaurants, which are high risk when community spread is rampant for many of the reasons that are summarized here, because people are up close, they're talking heavily, sometimes screaming, and ventilation is not always very good. This sneeze, we all know about the 6-foot level, but if there's a direct sneeze, those droplets are clearly going to go way beyond that. So 6 is a minimum. If you can be more than 6 feet away from people to avoid getting contact with a sneeze like that, you're going to be safer. One of the very vexing things about this disease has been, and unlike other SARS viruses, that people without symptoms can spread it. We now think that 1/5 to 1/3 or more of infected people never show symptoms or very mild symptoms that they don't even know they have. And so whether or not someone is asymptomatic or pre-symptomatic, those can still spread the virus. Now, whether they spread it as efficiently as people with symptoms is still unknown. It's suspected, but not quantified very well yet. We had that question on viral mutations, and this is a graph that shows the way some of the SARS-CoV-2 virus has mutated. So like any virus, it mutates over time, but actually biologically, it has some mechanisms that makes it less likely to have some large mutations over time as compared to viruses like HIV. And so as viruses go, it's mutating slowly, but there's no guarantee that one of these mutations may not have a very significant change, either in the infectiousness or the mortality or the type of symptoms or something. So it's something to worry about that could happen, but there's very little evidence that any of these variations, minor variations in the genetic drift of the virus, are having much impact on the disease severity, maybe a little bit, some suspect, on some of its infectivity. Staying on course of how we get the virus, there's kind of been a misunderstanding, or a clarification is probably the best way to put it, over how we get this. There was a lot of concern early on about surfaces and food, but it turns out those outside of hospital settings are not a major transmission route. Now, there's one caveat, that viruses falling indoors on floors and workspaces that can be stirred up by movement and into breathing spaces remains a concern. But mostly it's transmitted through very close contact, mouth to mouth, perhaps being stirred here. And some of it can be airborne enough that if we're not distanced enough, we can get enough virus to be infected. Now, there are a lot of things we don't know about COVID-19. People do seem to be protected from reinfection, most people, although there are a few clinical exceptions, but we don't know for how long, and only time will tell. And it's not clear why some people get really sick and some don't. It probably has to do with a combination of genetics, pre-existing conditions, the dose that you're exposed to, the route of exposure, and many other factors which haven't been quantified very well. One of the interesting things I found just reading about the other day was, why aren't children bigger spreaders of the disease? And it might be something as simple that children's breathing space is much lower below adults. And so you're not directly in the stream of a child's exhalations or sneezes if they are infected. And that may be why adults and other people are not as easily infected from children. And then we don't know how much virus it takes to get infected and seriously ill. These are very difficult studies to undertake, very expensive. There aren't many people in the world that study that issue, although they are now. And we're just beginning to get a better handle on how much virus and what kind of shape the virus has to be in to get different people infected and seriously ill. All right, let's switch over to the epidemiology. Before I get into that, I want to remind people to go ahead and enter questions in the Q&A on the Slido platform. We've got 4 questions there, and that's great. So if you have any others that have come in, just go ahead and enter them there. So from a worldwide perspective, the numbers from Bloomberg this morning were 27 million cases confirmed worldwide. Of course, the number of cases is much greater than that because many places don't test or can't test. But those are the confirmed numbers. And there's been almost 900,000 deaths worldwide. And again, Antarctica is not yet on this slide. In terms of the US, that continues to lead the world, both in total deaths and in total cases. And no one's really close. Brazil is number 2. India is a concern. It's coming up. It's moving very rapidly up in cases and deaths. And we know they're not doing as complete a job of testing. So India is a concern, as well as Mexico and the UK. The picture is a little better if you look at the mortality in terms of death rate and case rate. So death rate is the rate in the total population. The case rate is the percent of the proportion of deaths among those that are infected. And there, the US is 3rd in the death rate and 2nd in the case rate. Certainly nothing to be proud of. It has impacted so much on US mortality that COVID-19 is now the 3rd leading cause of US deaths, behind only heart disease and cancer. So from a cause of death that wasn't there in January, it's risen to number 3, more than unintentional injuries for the whole year, chronic respiratory diseases, stroke, drug overdoses, Alzheimer's, or diabetes. I'm not going to get into how cause of death is determined. There is some misinformation out there about some misinformation about how cause of death is determined and that it might be artificially inflated. I spent most of my career working on classification of diseases. The professionals that do that work are not swayed by money or politics. There are very complicated and detailed reasons on how cause of death is assigned, and multiple causes of death are assigned. And there's nothing untoward about the way this has been measured. So in the US, that has led to 6.43 million deaths and 190,000, 6.3 million cases, and as of this morning, 190,000, almost 191,000 deaths. The good news, and it's great news, is that the average change in cases on a weekly average has been plummeting the last week. The average, the case count has gone down 16%, and the death count, the change in deaths has gone down 16%. So after the summer, the nationwide COVID-19 infections had leveled off and have been dropping. For now, the worst may be over, but the average daily infection rate remains way too high in many places, still going up in a few, and we'll show those in a minute. And complacency is very likely to lead to new outbreaks. And I want to reinforce that it's not one epidemic, it's actually many. So what happens in Wisconsin and what happens in Texas can be very different things, even though we look often at the national figures. And what happens in Dane County isn't necessarily what happens in Door County. So even though it's dropping in much of the country, we still see some hot spots. Some places have seen a very significant change over the last 2 weeks. Some have seen an increase, and this varies all across the United States. Another way of looking at the hot spots are to look at the 7-day test positivity rate. This looks at it at a county level, and this measures the percent of tests that come up positive. And the higher that percent is, the more active the virus is in those communities. So you can see on more of a granular basis, those areas that are currently suffering from a high test positivity rate versus those that have a lower test positivity rate. Now, this test positivity rate has changed over time. The worst period was in April when the epidemic was at its worst on the East Coast. The summer spread to the West Coast, built back up again, and it's slowly gone down and is now hanging around 5%. We'd like to see it way under 5%, and there's no indication that we're going down very quickly at this point. Here are where the new cases are higher and staying high. This is from the New York Times. You can go to this site daily and look at this information. This shows the states where new cases are higher. It had a daily average of at least 15 new cases per 100,000 people over the past week. You can see North Dakota, South Dakota, Iowa are leading the pack. Can you say Sturgis motorcycle rally, anybody? And this is a measure from COVID Act Now that looks at several measures and combines them and forecasts what areas have an active or imminent outbreak. Again, North and South Dakota, probably due in large part to Sturgis. And then we have a large area of the country that isn't changing very rapidly, where cases are still high. They're at risk of an outbreak, even if they're low. And then we have the places in yellow where disease growth is slowing, and one lone state where it's diminishing rapidly, and they seem to be on track to contain COVID. So this is a very good site to look at. I think you can also get things on a county level if you're planning on taking a trip and want to know what areas perhaps to avoid. I'm going to move over into Wisconsin now and turn things over to Brittany in a second. Is Brittany online?
Yep, I'm here.
Great, Britt. I'll move the slides for you if you just tell me to go next once we get to Madison, Dane County. So this is the current picture in Wisconsin as of yesterday from COVID Act Now. We built up to a summer peak, and then as school started in September, looked like that decline ended. Whether we're on a plateau or going up or down now is kind of hard to say. We certainly have too much virus in most of the counties. And this warning system here from COVID Act Now, again, is a compendium of different indicators that add together that give us a good idea of which areas are at risk and which areas are at lesser risk. And it's based on the daily new cases, the current infection rate, the positive test rate. Almost all places, fortunately, have decent ICU headroom, and then the percent of tracers hired. And you can drill down to this on a specific county level. But Wisconsin's sort of in the middle, and we're certainly at a place where we're at risk of things worsening if we aren't more compliant. People are always interested where we're going to go. Well, nobody can see the future. Models take various assumptions into account and then try to forecast if those assumptions occur over that time span, what will happen. And this is a nice site that shows various models at once. And you can see the spread of how those models predict what the deaths may be in Wisconsin over the next month. Most of the models suggest a plateauing or slightly lowering of the deaths over the next months. A couple of them show deaths soaring, and that might be assuming that distancing doesn't take place, that bars reopening, that a certain percent of people don't wear masks and so forth. And these are models that you need to take with a grain of salt, look at what the assumptions are, but you can get an idea at least of what the range of scenarios over the next month or two might be like. No model has turned out to be perfect. Some have turned out to be very inaccurate. And so that's why I like to look at this ensemble of models to get a feel of what all of them are saying together, if you want an idea of what we think might happen, depending again on assumptions in the future. So we're down to the Dane County level. I'm going to turn it over to Brittany Grogan.
Hi everyone, good to be here. Data analyst. I'm Brittany Grogan, data analyst with Public Health Madison in Dane County, or PHMDC.
Speak up louder, Brittany.
Oh, sorry. So I have been on our COVID data team since March. So we've been working a lot on our local data analysis and presentation and developing metrics and all of that. So I'll just give a really brief overview of what we've done, what the data looks like, what our metrics look like. You can advance to the next slide. So, not sure if you can see the full slide here, but this is our new cases by day in the gray bars over the course of the epidemic. And then the boxes show various interventions or events that have happened. So our first case was identified February 5th. We were one of the first in the whole country. I think we're maybe number 11 in the country to have a case. So our response has really been happening for a long time. We developed a incident command structure back in January and have been working on COVID the whole year. So Safer at Home statewide was implemented in late March and then overturned in mid-May. And in late March and early April, if you can see it, there's a kind of small spike. It looks like a small spike there. Of course, at the time it seemed larger, but we know that there were a lot more cases in the community than we knew about. We really did not have nearly the testing access and infrastructure that we have now. That was also when we had our highest % positive happening in late March, early April. So we know there was way more cases in the community than what we actually have confirmed. So after Safer at Home was overturned, we immediately put in our own local Safer at Home order that was in place for about a week before we moved into Forward Dane Phase 1. And I'll talk a little bit about Forward Dane in a little bit, but that's kind of our local plan for how we decide to move forward and open things back up. So all through the time that Safer at Home was in place, we had been working really hard to develop the Forward Dane plan and metrics that would determine our reopening and phase movement. So we were in Forward Dane Phase 1 for a few weeks, and then we moved to Phase 2. After Phase 2 is when we started experiencing a spike in cases, which you can pretty clearly see there shortly after we hit 1,000 cases. Through contact tracing, we identified many of these cases were young people who had been going out to bars and having gatherings with each other. We also know that some bars and restaurants didn't open during Phase 1 and waited until Phase 2 to open because it didn't really make sense for them to open at 25% capacity, which was what Phase 1 allowed. So they waited to Phase 2 where it allowed 50% capacity. That kind of led to this big spike in cases. So then we implemented further orders further restricting capacity at bars and restaurants, and also instituted our mask requirement, which was the first in the state. And those combined really worked successfully at reducing our cases. And we know that Dane County had a really high mask usage even before our orders were implemented. So we think that, and we also announced our mask requirement order about a week before it actually went into place. So it might look like it didn't have that big of an effect, but we think that mask usage really has helped keep our case counts down. And then, as you can see, we recently had UW-Madison open. They had their first day of classes a little over a week ago. Students moved into dorms the week before that. And we had record-breaking days of number of cases on both September 5th and 6th. And if you have not looked at our dashboard yet today, we have more than doubled our record. We had 456 cases yesterday, which is over 2 times higher than our previous record of 195 on the 6th. So not good. We know that UW yesterday announced they were going fully remote for 2 weeks. They're quarantining several fraternities and sororities. They are quarantining 2 dorms. A lot of our cases are coming from UW, which I'll also talk a little bit more about in a bit. All right, next slide. So this is our dashboard. I'm assuming most people have seen it, so I won't go into great detail, but just wanted to make sure people knew about it. And I circled in orange a couple of things that I wanted to point out, which is just that I know that on some, if you have like a small computer, like I took this screenshot from my laptop with a small screen, so things can look kind of smushed. So in each corner of every box on the dashboard, there's this little button where you can expand it to full screen for that specific box. And it makes it a lot easier to see, especially with these graphs in the middle and the bars on the right side. And then at the bottom, for the graphs in the middle, we do have 5 different graphs that are in this middle section. And just wanted to make sure you knew about that because it's not always easy to see this arrow at the bottom where you can switch to the other graphs. So we have this main one that shows up, which is the cumulative cases by date. The next graph shows new cases by date and the 7-day average of cases by date. The next graph is number of tests by date. The graph after that is the percent positive and 7-day average of percent positive by date. The next graph is the current number of inpatients with COVID in Dane County hospitals. And then the last graph is current patients in the ICU with COVID in Dane County hospitals. And then on the right side, we have graphs for demographics for cases, hospitalizations, and deaths. And those show age, sex, ethnicity, and race. And then we also have this note box in the bottom left corner that gives more information about some of these, some of the data and how it's calculated. And also on our website, we have frequently asked questions that gives a lot of good information about this data. Next slide. So this is our most recent measures from our Forward Dane plan. We release a data snapshot every Thursday that gives an update on these metrics. So we're releasing one today. It usually is at the end of the day around like 5 p.m. that we release it. So we post it on our website and then we'll also post it on our social media accounts. We've been doing this since the end of March and all of our past issues are on our website if you want to check them out. It always covers the most recent 2-week period. And we give a few days just to make sure we get all of our cases and tests processed and so we're able to complete interviews with cases. So today's release will cover August 25th through September 7th. So we have these colors for our different metrics. We have green, red, and yellow. So green is the best, yellow is in the middle, and then red is the worst. We also calculate the same metrics for the southern region, which includes Adams, Columbia, Dodge, Grant, Greene, Iowa, Jefferson, Juneau, Richland, Lafayette, Rock, and Sauk counties. So last, you can see that, right, and I have another slide too, which shows the rest of the metrics. We have 9 total metrics, so this is showing 6 of them. On this page, the only red metric is the average number of cases. Last week we had an increase in the average number of cases for the first time since our data snapshot that we released on July 13th. So we're seeing a decrease, and now we're going back up again. And we've had our percent positivity and testing have been green for a while. We have very robust testing in Dane County right now, mostly due to the Alliant Energy Center being open. Next slide. So these are the other three metrics. The one in yellow is our lab timeliness and contact tracing. So how long it takes for someone to get contacted after the day of their test. So we want that to happen in 2 days or less. We've improved this recently, but we are close to red, which is less than 70%. Exact Sciences is processing tests from both the Alliant Energy Center and from University Health Services at UW-Madison. So they've been very busy lately, which is impacting the lab timeliness. Our contact tracers have also been experiencing some difficulty contacting younger people like the UW students and getting them to name their contacts. So that metric could decline more today and over the next few weeks. But overall, for this 2-week period, 92% of cases were successfully contacted and given isolation instructions. So overall, our contact tracers have been pretty successful at reaching people. Okay, next slide. This is just an overview of the deaths that we've had in Dane County. This is taken from a 2-page publication that we released recently. I can send out the link to that so people can take a look. So this was published when we had 39 deaths. We have had 2 more since then, so we're currently at 41 deaths, which is overall low compared to the state and other counties in Wisconsin, which this mortality rates by age shows, which has Dane County rates on the left and Wisconsin rates on the right. So our rates are lower at every age group compared to Wisconsin. As age increases, risk of death from COVID increases. Same with hospitalizations. 20% of our cases from age 60 to 69 have been hospitalized. 30% of people in their 70s, 46% of people in their 80s, and 71% of people age 90 plus. And then our date of death graph shows that we really have not had too many recently, and usually not more than 1 in a day, except early on we had more, which we kind of attribute to lots of outbreaks in long-term care facilities. Those cases are a lot more rare now, which is great. We really got that under control. And when we have seen cases in long-term care facilities, it usually has been a staff member, a younger staff member. Next slide. All right, so I just have 3 more slides, all on UW-Madison, so I'll go through that quickly. We began tracking UW affiliation at the end of July, since we knew that students were coming back and there wasn't really a great way for us to track whether they were a UW-Madison student or not. So we created an identifier that allows us to track students who are testing positive. So lots are still being tested at the Alliant Energy Center. As of last week, 37% of UW-Madison students were tested at the Alliant Energy Center, and most of the rest were at University Health Services on the UW campus. Lots of cases coming from fraternities, sororities, dorms, those congregate living areas where people are getting together, but also lots off campus too. We share with UW the number of newly identified cases each day that we have identified as students and were not tested by UHS. UW is easily able to track students who test positive who are tested by them, but we share with them the students who get tested elsewhere. Next slide. This is a screenshot from yesterday of the UW dashboard with over 1,000 have tested positive so far, most from on-campus testing, but a significant portion also from off-campus testing. And they update their dashboard at 2 p.m. every day, so you'll see a pretty big increase, I think, later today. And next slide. This is something that we released a couple of days ago, that we have seen the majority of our cases being associated with UW recently. So from September 1st through 7th, we're now at 74% of our cases were UW students or staff. So we will be monitoring, right now, we have not seen evidence of spread outside UW-Madison, but we'll be monitoring that very closely to see if this is affecting the rest of our community outside of the UW campus. And like I said, UW has implemented several restrictions this week, and we'll see if that is able to successfully reduce the spread. All right, back to you, Hank.
Thanks, Brittany, for the local perspective. Very important and very personal to most of us. I'm going to have to move things a little bit quicker here, so I'm going to buckle your seatbelts as we go through some of the remaining topics, and I'm going to skip a few things. We've talked about testing a little bit, but I want to remind people that testing is done for many different purposes. It's not just for clinical diagnosis, but also for public health surveillance and testing the pattern of disease exposure and in fact, the virus exposure and the patterns of disease. There's a lot that's been done in the US, although lately it does seem to be leveling off. You saw the percent positive earlier. But these are almost all PCR tests, very expensive tests. I'm not going to have time to go into the weeds on testing, but I would recommend this recent article by Atul Gawande for those of you that are interested in understanding testing in a lot more detail. Very comprehensive article, very readable, I think, by the general public, and a lot of new ideas about how we can improve testing, both from a personal as well as a public health standpoint. And I want to remind people that if you need to get tested, and anybody that wants a test can get a test, although I wouldn't recommend it for everybody, there should be some sort of need. There's a lot in Dane County. You can go to your healthcare provider, the Alliant Energy Center, UW-Madison, there's the South Madison community site, different community pop-ups, and many different pharmacies are offering it. Briefly, treatments. You've heard about most of these, and I'm not going to touch some of them for some pretty obvious reasons, but this drug has gotten a fair amount of attention. Unfortunately, it's an expensive drug. It's an IV drug, and it's also very hard to utilize before severe disease takes place because it's an IV drug. There's very little information that has had any impact on mortality, but it has had a modest impact on reducing the length of a hospital stay. Some very recent evidence from the WHO on steroids has been very positive. They just issued new guidance recommending steroids to treat severely and critically ill patients, not those with mild disease, and found an amazing 1/3 reduction in deaths. So this is probably one of the most important tools now for reducing deaths among those with severe disease. Convalescent plasma was recently in the news. Unfortunately, there's no evidence for robust impact for it, and it's probably not going to be any sort of panacea. Relative to convalescent plasma or monoclonal antibodies, which is more specific and more highly concentrated, some of these are promising, but they're not here yet. They're still being studied. And if they are measurably or very successful, they're going to be hard to scale up because of the way they're produced, and they can be expensive. Still, it would be nice to have this as an armament especially if it's more active and more effective earlier in disease. But we don't know yet. And then a very exciting study from a small Spanish pilot study just came out showing reduced ICU admission from 50% to 2% among COVID-19 patients with a form of vitamin D given in high dose. If, and it's a big if this holds up in larger study, better controlled studies with larger populations, this could also, if not a game changer, be a very large increment to reducing the severity of the disease. But we're still waiting overall for that high impact drug or drugs that are both affordable, readily available, can be given orally so that it's easy to use, that acts rapidly, and that is active during all phases of infections. That does not exist. And so what we need to turn to are the vaccines. Vaccines have been in the news as well. This is going to be a very brief overview. Obviously, the AstraZeneca timeline here is off, since that's the vaccine that had a side effect that raised concern and stopped the trial. That's not unusual to happen as they study it and see whether it's related or not. At the minimum, it will delay rollout of the vaccine. But you know, there's a huge number of vaccines, all in different phases, all using different techniques. And that's why we're somewhat optimistic that we will get something, because there's so many different kinds of vaccines being looked at. But as you can see from this timeline, it suggests we're not going to see much until 2021. And we're probably not going to see a big rollout till way into 2021, because there are there's 7 million people in the world, billion people in the world. That's a lot of doses of vaccine to get out. So it's going to take a while. I'll skip that. The key vaccine questions that remain are: how safe is a particular vaccine? Does it protect from both infection, and that therefore maybe you spreading it to others even if you don't get sick, and from disease? How durable the immunity is, how long it lasts. Will there be enough new infections to show it protects? As infections drop off in many places in the US, some of the studies may have to take longer time as we wait to see whether enough numbers are there to show how it protects. Does the vaccine work regardless of age? Does it work on the young? Does it work on the elderly? Does it work on people with some pre-existing conditions? We're going to have to wait and parse a whole lot of data to answer that question. And then how many doses are needed? That's what they do in these trials. They look at different doses and different combinations of doses and dose concentrations to see what works best. Again, that takes time to parse out. And then once we know what works and if it's safe, we have to ramp it up. We got to make it. We have to get the supply chain built. If it requires a cold chain, we have to build that in. And then comes the decision of who's going to get it first. I just looked at briefly the CDC draft planning document, and it suggests that healthcare professionals are going to get it first. And then essential workers, defined broadly, including national security and public safety members, agricultural workers, educators, and people in the food industry, and then the long-term care facility residents and staff. For the people who are gathered around this town hall today, you'll notice that, you know, the general healthy elderly are not in this first group. So if this draft holds, we're not going to necessarily be first in line, but maybe second or third in line. One big question is how the public is going to respond, and that's a big concern of mine. There's a recent estimate that 50% of the US public is considering declining vaccine, and if you multiply 50% efficacy of the vaccine times 50% coverage, that means only 25% of the US population might be protected by a vaccine once it's fully rolled out. And unfortunately, this is divided up, as many things are in our society today, by what part of the political divide you're on, with Biden supporters being much more likely to say they would try to get vaccinated, and Trump supporters much less likely. So the vaccination is going to be adopted unequally if this holds over time. We clearly need new approaches to public outreach, the health departments, the leaders, and the agencies responsible for this at all levels of government are going to have to really work hard at outreach to improve these numbers. So there are two things that Andy Slavitt, one of the people I follow on Twitter closely, has said about vaccines. It can end a pandemic, but done wrong, it can also end vaccines. I was pleased to see all the major vaccine manufacturers in today's Wall Street Journal put a pledge out that they're not going to cut corners despite political pressure to do so. And that's a good start because public trust is just as important as the efficacy of a vaccine, as I just outlined. So we're not going to have a vaccine for a while. What we have to worry about for the next few months is continued importance on non-pharmaceutical interventions. This is a great slide by Hu-Ling Yan of University of Hong Kong that summarizes all these things. This is what happens in an uncontrolled situation where we don't control the source control, where ventilation and filtration in a room doesn't take place, where there's no distancing and PPE and masking and no hygiene. What we need is a combination of interventions across our society that includes source control and receiver control, in other words, mask wearing, ventilation and filtration in all susceptible areas, distancing and avoidance of crowds, and hygiene. When you clean up all the viruses in that way versus the uncontrolled situation, we can really reduce the spread of this disease. And we know that from what other countries have done. Mask wearing works. It's not a panacea. It's not a perfect solution, but it's one of several. And we know that those places that have masked up, as we saw in Dane County, as we saw here on a larger level and in many other studies, that masking can have a big effect. Everybody wants to know which masks are affected for COVID-19. The ones on the left here are the ones that have been recommended by this group. Surgical masks are great. They're good fit. They're easy to fit. If you don't have access to those, even though they're getting more and more accessible, you can make a multi-layered cloth mask. And these others are still pretty good, a single layer cloth mask. And some of these are not as well recommended. There is the Hank Weiss solution. If you happen to have one of these going around, which isn't recommended because you can exhale through this valve to a population that you're near, people that you're near, combine the two, where this underneath this mask, and so you avoid the exhaling into other people's region. You get to keep the efficacy of protecting yourself with a mask like this. And no, I haven't patented this solution yet, but it's the kind of thinking that we need to approach, is to make this the most efficacious tool that we have. So I think I'll skip, no, I'm going to go through Tom's control. He's the former head of CDC. He has a nice blog and is on Twitter actively. You can imagine how frustrated he is that he's not running the agency these days. But this is how he says we can get COVID-19 under control. It's not rocket science. We should have a true national 6 to 8 week stay at home. We failed at that earlier. It's unlikely politically that we'll have it again, but we should do it, and many other countries have done it. We should, failing that, close bars and indoor gatherings until spread is controlled in each area. Wear a mask, the 3 W's, wear a mask, wash hands, watch your distance. Wear masks when you're near people outside the home. Prevent clusters by testing, tracing, and isolating. And it's great to hear that the public health of Madison, Dane County are doing a great job on tracing. Most county health departments are not able to be as effective as that. We should also have effective, affordable quarantine for household exposures. They're doing that to some extent on campus exposures, but we're not doing that very well in most communities in Dane County, much less in the US like other countries are doing. We need better and more appropriate timely testing, including a new generation of rapid tests so that we don't miss active infections. We need to protect our ongoing healthcare system. We need to protect high-risk workers and people in high-risk settings, and we need to use good data to drive progress. It's really important, I think, as individuals that we stay informed. Again, we have the politicalization that leads to misinformation, and it's unbelievable to me how the red-blue divide has changed and impacted on the way we even think about the impact of this virus. These are just unbelievable numbers where 90% of the Democrats think that the number of deaths we've had is not acceptable, but only 43% of Republicans think that it's not acceptable. We should be united as a nation, and we should be feeling very much the same about how we approach this, but that's where we are right now. But I think health agencies and political leaders have to work on changing that. For key sources of information, all these slides will be available. You'll be able to go through these sources of information. All these are live links, and you'll have access to them to browse through them at your desire. This is where I go to for information. I'll highlight one here, the COVID event risk assessment planning tool. It's a great website that you can key in what county you're in, how big a venue you're planning to have, and it will tell you the risk of someone having COVID at that event based on countywide statistics. So it's pretty cool for showing how anything over 25 or 50 people you're likely to have at the levels that we're seeing now in Dane County and in other places, somebody there with COVID. I've also found over the course of the pandemic very early on that Twitter is an amazing tool. And I know some people don't like Twitter, don't use Twitter, but you don't have to be a Twitterer to enjoy the benefits of seeing the information that other people are putting out on Twitter. So I don't put much stuff out there, but I follow these people daily. It's an incredibly diverse, incredibly intelligent, incredibly passionate group of people. These are the ones I follow. I'm sure other people have other recommendations to make. But again, afterwards, take a look at these slides. And if you're interested or you use Twitter, follow some of these people for a while. You'll be amazed at the level of thinking, the level of concern, and the forward thinking that takes place, as well as the truth and the accuracy for what I think these people talk about. And of course, as Twitter goes, it's extremely up to date. There's also a huge amount of continuing education. That's what Plato is based on, lifelong learning. These are some of the websites and webinars and podcasts and academic courses that you can take on your own. I started out very early with John Campbell's Down Home British YouTube updates and followed him over the course of the pandemic. Again, I followed Tom Frieden. APHA has had a lot of good conversation. Andy Slavitz in the Bubble podcast has some great guests. There's the Osterholm update, and then these others that you see here. This is a course that I'm taking now, pretty academic, but again, there's no cost, and you're not graded, and they've got some great speakers, including Tony Fauci coming up. So this is where we're at. First, a couple of thoughts from Tom Frieden. We're still not finding most sources, less than 10% in most of the country, and we're not quarantining most contacts in most of the country, so risk remains. There are fundamental principles of communications on health emergencies that we're not following. Be first, be right, be credible, be empathetic. Share practical ways people can protect themselves and their families. And unfortunately, each of these principles is currently being violated by much of the current US government response. And he says COVID-19 will continue to undermine health, jobs, economy, and education. Our fundamental error has been failure to recognize that we're all in this together. And then my final thoughts. I don't think we can scrub and bleach our way to reopening. There's too much hygiene theater, which is an excuse for people to look like they're doing something. But that's not the most important thing that we ought to be doing. There has been unprecedented rapid progress towards a vaccine. That's a hopeful area. And I think we can be hopeful that useful vaccine tools will be widely available next year, despite some fits and starts. but as I said earlier, they're not going to be a panacea. The politicization that we've seen has been unprecedented and dangerous. And I think the threat remains, partly because the many pandemics toll is largely invisible, and because of that, population and institutions are going to be further compromised, harming local, national, and international responses. We're really at the end of the beginning, a period in which we have squandered a whole lot of time. We face the now looming fall and winter with many of the same systemic problems we had in the spring and summer. We all want to return to normal. We need to accept, though, that we're in the middle of a disaster. And after disasters, things rarely happen, rarely get back quickly or ever to normal. There is a real danger, we're seeing it now in many places, that we might stop treating the epidemic as the emergency that it is. All I can say is this is not the time to give up, and we all have to send that message to our friends and politicians. So far, this is where we're at. Less than 20% of Americans have been infected. We have tools to keep the numbers down till the vaccine can come and help things. But what happens next, and whether that 80% will be affected or not, is going to be up to us. So I see we've had a lot of questions come in. I thank you for your attention. I apologize for going a little bit over. Please upvote some of the questions. I'm going to turn things over to Meg to help show the panel, to introduce the panel, and we'll just take some of these questions as they come up. Meg, you can see the questions. You want to read them off like you do in Plato, and just see who will go with it?
Yes, that would be fine. Thank you, Hank, very much. This is Meg Taylor, and I was the person in charge of the work group committee that was established by the Plato board to help the Plato board in the development of criteria to help them as they look to reopen in whenever that day arrives. We also wanted to provide the Plato board with reliable data and methods by which they could make their decisions based upon scientific data. There were 5 of us on our work group. It was established towards the end of May, and we submitted our draft criteria document to the board at the end of June. So I want to introduce the board members. They are on the panel live with us right now. And depending upon what the question is, I will try to feed those questions to a specific member. You know who Hank is. We always call him our data guru, and he has been so critical as we were developing the criteria document. Dr. Henry Anderson is a physician, board certified in occupational medicine. He was also the chief medical officer and state epidemiologist for the state of Wisconsin Division of Public Health. Ted Goodfriend is a physician as well. He is a retired physician who worked at both UW and the VA. He has a lot of pharmaceutical study knowledge, and we think of him as our primary physician who is looking at individual health, public health. We're looking at population-based health. And he always tried to bring us back down to the individual patient as we were looking at criteria development. Jim Thiel is an attorney and spent his career mainly at the Department of Transportation. Jim had a fabulous expertise in emergency preparedness. And as we looked at any of the transportation issues, as well as legal issues, he provided a wealth of information to the advisory group, or the work group rather. And with that, we'll open it up to the questions. A lot of the questions that were on Slido were actually answered, but I'd like to start with the first one about when Madison and Wisconsin will adopt the iPhone exposure warning system. And hopefully Brittany might still be on, that she could provide us any insight into that at the county level. Hank, is she still on?
Yeah, I'm still on. As far as I know, within the data team at least, we have not talked about this. So we don't have plans for that. I don't know exactly how useful that something like that is. I haven't seen data on it, but we basically tell people to act as if they have COVID and to act accordingly. And so that would be taking all precautions no matter what. And we've had a high COVID activity level in our county for months now. And so I don't know that this would be that useful. I'm open to hearing otherwise, but that's kind of our position right now.
Thank you. I would only let the audience know that, interestingly, it is sitting on our iPhones right now. It's easy to go to your, I think it's settings, and it's there, and it's obviously not activated, but it is an intriguing way of looking at exposure rates. So thank you, Brittany. There was a question about someone who lives in downtown Madison, and as we all know, as of last night at 8 o'clock, it's real clear that the university and downtown Madison are viewed as hotspots. And so as someone who is living downtown, the question is, what do? We are afraid to go out of the place that we live and do our exercising. So I ask if anybody in the panel has any advice that they wish to offer the person who asked that question.
I'll give that a try. This is Ted Goodfriend. I'd answer that question by saying, would you like to play Russian roulette? It's a terrible risk to go to public places now, no matter where you live. And depending on your susceptibility to the serious consequences, it gives you more or less reluctance to expose yourself. No matter how low the incidence goes, if it isn't zero, there's a risk. So I can't answer that with anything except it depends on your risk aversion or risk acceptance. It's always going to be a risk. I don't know when it will stop being a risk.
And this is Brittany. I'll just jump in again. I also live downtown, and I would recommend avoiding, so Japan has a cool campaign where they say avoid the 3 C's. The 3 C's are closed spaces with poor ventilation, crowded places with many people nearby, and close contact settings such as close range conversations. So based on that, I would personally avoid like eating indoors at a restaurant where people are not going to be wearing masks. It's a closed space. People can be close together. I'd avoid places where there's a lot of people, especially if they're talking and not masked. That might include like churches or something like that. Again, it is about your risk tolerance. So you kind of have to think about that. But yeah, I'd say that following that, avoiding those sorts of spaces is important. And just to say that we have not identified any outbreaks in Dane County that were associated with outdoor spaces. Nothing really significant has come from that. So we see the outdoors as pretty safe, especially if you're masked, especially if you're trying to distance from other people.
Thank you very much. There was a question that came in from Steve. Why is Canada doing so much better than the US? And I think we'll start with Hank, and if you can give any advice.
Well, I was hoping Jim might answer that one. You want to take a hit at it, Jim? No. Okay. Well, I've seen a few articles talk about that. Maybe the Canadians are just nicer than we are. No, I'm teasing. Canadians are pretty much like Americans in many ways, especially biologically. But they worked at it earlier. They acted earlier. They also have a national healthcare system. So people don't have to worry about getting treated. I think their testing was also done earlier and better aimed than some of ours. Those are some of the things. I don't know much more about it than that. If anybody else wants to chime in.
Well, I would only say that a friend of mine, and we were speaking on the phone about a week and a half ago, and she really has, we are all in this together. And that's coming from the Canadian government and the Canadian people, much more than what you see in the United States. And COVID itself has not been politicized the way that it has been in this country. She said that she would not even consider leaving her apartment to get into the stairwell or onto an elevator without being masked, and never leaves without a mask on, and doesn't leave very often. Even if she is going to do her laundry, which is on a different floor, she would never consider doing that without being masked. And it has to do with the community and the concern for everyone. That was one of the things that she said to me. So if she is representing the Canadians, she's doing a very good job at it.
Yeah, I would just underscore the politicization of it. I think in Canada, all of these kind of outbreak things are really approached as a health issue and a public health issue. They have a strong public health system up there. And I think people are used to a centralized source of information following the direction. I think it was well organized from the top down early on there. I think there was some issues regarding the transfer, the travel across the border. It still is an issue. Being a fisherman, you'll get caught if you go up into the borderlands and take your boat and leave the US and want to go in and fish in Canada. They're right there to send you back. So it's really being kept pretty tight as far as people coming in. But I think the attitude of the population is really quite different up there, and acceptance of advice on the public health standpoint.
Also expanding on one of Andy's points about the public health system in Canada, you know, per capita, it's much better funded than the US. The public health system in the US has been on a major decline for many years, and they haven't had the resources and the expertise in many areas. We're spoiled here in Dane County to have the quality of the people and the number of people, but you know, I'm sure they'd be the first to admit if we asked them over a coffee or a drink someday when this is all over, that they could use a lot more people, and a lot of things aren't being done because they prioritize things in the emergency right now.
Moving on to Michael's question, what is the difference between isolation and quarantine? Andy or Ted, would you like to take that?
It's somewhat of a semantic issue. I mean, quarantine has been around as a medical terminology and a legal requirement of you can quarantine people, which carries with it an ability to order things, where isolation is kind of the process. The goal of both of these is to keep people from getting near other people and infecting them. Isolation is just how you do that, by not getting near anybody. Quarantine is taking it a step further to actually be a requirement, have some legal status behind it. Quarantine and public health has been around, just thinking in terms of TB and other illnesses where quarantine has been used quite effectively. So At least that's my understanding. Haven't looked it up on the internet yet, but I think both of these are similar processes, just a little different basis how they start.
Well, and I would only add a few things, Annie. First one is that the Wisconsin public health statutes do give the authority for public health agencies to quarantine based upon what disease entity it is. And we'll also see that when someone goes in to be tested, if they are showing any symptoms before we know if they are in fact COVID positive, they will be instructed to isolate. But once someone has shown positivity, they will in fact be quarantined, which is giving them more of a legal push that you are going to stay behind closed doors, and we will help you make sure that you have food and drink and that sort of thing. So total agreement with that. I would say that's the difference between the two of them.
It's interesting that the word quarantine comes from the fact that it used to be for 14 days.
Interesting. Roberta's question was, will some version of this virus probably circulate endlessly, as we've seen with others? Is there someone there who feels they can answer this question?
I would say yes, it will circulate. And now that we have lab tests to test for it, it'll be one of those things that when people come in, they may get tested for. So as we track it, the likelihood that it'll be eradicated, we've not been terribly successful at eradicating many diseases. So it will be around. It's only how much and how prevalent it will be.
During some of our discussions in the work group, we talked about there were a couple of scenarios that might play out, and in some cases, a virus does in fact weaken as it circulates more and more and more, and we're not seeing that with COVID. And the other issue, well, that's the most important one, I guess, is that they sometimes become less virulent, but we are not seeing that with COVID. If that is in fact the case, Andy?
Yeah, I think we're getting to learn more about it and how to treat it and what to do about it. I would just add to my other comments that this is an international, worldwide infection. So this may be an issue of the difference between Canadians and the US. We may travel a whole lot more and have a whole lot more international travel. And as we open that up and we have a lot of money, so we're going to be vacationing in different areas, we tend to let our guard down. As long as there are areas in the world where there are infections, that's going to be an issue, and paying attention to if there are advisories out of where to travel because of illness and vaccination. This may become, if the vaccine is a good one, that just as you travel to a yellow fever area, you're advised to get a vaccination for it. And I would hope that this will be one of the vaccines that will then be incorporated into our international travel recommendations for travelers.
That's a great point.
Meg, let me just break in here for a second, remind people to upvote questions. We'll try to get to as many as we can, but the ones that are most popular we'll get to first. So there's still 9 questions up there if you select your most favorite. Otherwise, maybe we'll just take them one by one.
Where do barbershops and hair salons rank in this pandemic? And I know that there were strict regulations. They were closed for a good length of time. From my personal perspective, I go to a hair salon, I am outside until I am personally she comes outside to get me. We are masked. She has disinfected the entire salon area that I am going to be in. There are stylists who have, if you have great concerns, you can go first thing in the morning before anybody else has been there, which gives you those hours where it has been cleaned and sitting idle. Does anybody have any other advice on where they rank and what your personal experience has been in barbershops or hair salons?
Well, like
I'll
many
take a
of
shot
our
at that.
spaces, it depends. It depends on the procedures that are done in that particular place. There are reports in the literature about hair salons in which it turned out that some people weren't infectious, but people were all wearing masks and no customers got infected. So I feel pretty good about going to a barbershop where they manage who gets in, the numbers, everybody's masked up, everybody has an appointment and only goes in then. So I personally have been going to a barbershop that seems to be having reasonable procedures, but that's an individual decision, as Ted said. If you want zero risk, let your hair grow for a while.
And I would just add, and maybe ask Brittany, one of the challenges has been getting the information on that so that we don't have good occupational exposure information. I mean, a lot of businesses, a lot of large manufacturing facilities have been open throughout the epidemic, but actually getting information on where do the cases work is a challenge. And I would just kind of a rule of thumb, if you look at a hair salon is, or any place you go look around and see how many people are near you. And most of the hair salons, at least the ones where I've been, they're very good at the number of people you're going to be near is kept to a bare minimum. So the real issue is for the hairdresser, is a person coming in, they run across a lot more people than a client coming in is more concerned about, is the hairdresser symptom-free and free of disease. So it is a risk, but I think just look around and see how many people are around. You go into a bar, there's a whole lot more people you can see most of the time than elsewhere. But Brittany, are you including hairdressers on the follow-back questionnaires?
Yeah, like you said, it can be difficult to identify, but we do open outbreak investigations into facilities where an employee has worked while they were infectious, or we identify like multiple cases that were there. Throughout this whole epidemic, we've only had, I think, one investigation into a hair salon. So it's very low. And of course, they weren't open for a while at the beginning, but I do think that the required masking for everyone has been really important in preventing spread in those places. So still a risk, but overall in the grand scheme of things, fairly low compared to other indoor places, it seems.
Going on to the next question. Let me pull it up. The best case scenario, when might in-person, indoor, unrestricted gatherings for UW-Madison or other groups be possible or safer? Number one, that's going to be a question that the board will answer based upon the criteria that they are using and the information that they've received. But keep in mind that Forward Dane is the guidepost by which everything will revolve. And so it is the minimal requirements, and we will certainly have to be allowed by Forward Dane to even consider anything like that. When the work group adjourned, we agreed that we would continue to meet on a regular basis, looking at data and seeing if any of the restrictions that were applied in our criteria would need to be modified. At this point, we do not. And I think that Ted, Dr. Goodfriend's biggest statement about the criteria guidelines, a protective vaccine in conjunction with effective treatment therapies are the only true guidepost for safely opening to all in-person activities again. And what we were really trying to stress in our criteria development is that virtual classes have been extremely successful. And it's something that we certainly should be carrying forward as an adjunct if we find that we're going to be able to have in-person classes in the future. I don't know, Brittany, if you have anything to add to that, or if anybody on the work group wants to give a best case scenario date when things could open up.
Yeah, not much to add. With all of these UW cases, it's hard to say when that will get under control. I do think right now we allow indoor gatherings of up to 10 people if they have masks on. So I probably would not see that changing in the near future.
Right, yeah, yes. Ted,
Let me make a comment, Meg.
Yes.
It may also depend a lot on what each venue may require as a condition of opening it up to a bunch of old people going to a Plato class.
Exactly, yes.
And that may be as much even if you meet the minimum requirements of forward Dane, you may not meet the minimum requirements of that venue.
Right, and in our document, we also talked about, the issue of going to a different city for a theater performance if the theaters open up. And then there is the issue of transportation. So a lot of those things were addressed in the criteria document, and maybe the best answer for this particular question is to go back to the guidance document and read what advice and what considerations we had included in that document. The next question, are minority groups overrepresented in the Dane County statistics?
This is Brittany, and yes, they are. And in our data snapshots that I mentioned that we release every Thursday, we do have a demographics page. So we look at the demographics of cases, hospitalizations, and tests from the past 2 weeks. So you can kind of see the more recent trend. And overall, throughout the epidemic, our Black residents make up about 6.5% of our population, but 10% of our cases and 17% of our hospitalizations. And our Hispanic residents also make up around 6.5% of our population, but account for 14% of our cases and about 18% of our hospitalizations. So we are seeing those groups overrepresented in our more severe cases.
The next question is really about current treatment modalities, and I think that Hank answered this question pretty thoroughly during his presentation. Hank, would you agree?
Yep. Hopefully.
And the next one is really just something for Brittany to just see that someone had a comment, though you really did a good explanation on maybe what we need to be doing are pushing those two buttons on the dashboard, and we'll be able to make it less difficult to read. But this is a comment about the Dane County dashboard.
Yeah, and I will just say that we are researching a different platform to use, since the one that we have has not allowed us to make a mobile-friendly version. So it is possible that in the maybe not super near future, but hopefully soon, we will be able to have a more mobile-friendly platform. And then for focusing on the past 14 days, that might be something we include if we do switch to a new platform for the dashboard. But I will just recommend again to look at our data snapshots released every Thursday, because those give a lot of really detailed data on the past 14 days. And then I can, I see the next question is also about Dane County. So we right now do not report cases by zip code anywhere. But if you do want to look at that really granular level, the state health department, DHS, does post a map of cases by census tract on their website.
Okay, thank you. What are your thoughts about the reliability of the COVID-19 data as it's coming in from China? Hank, do you want to start with that discussion?
I'm not really in a position to know. No country is doing it perfectly. Clearly, early on at the local level, China hid what was happening from the public, and they hid it from their own government. They've since improved on that tremendously. They're also one of the leaders in vaccine development, but detailed on who they're testing, how accurate their tests are, and how well they're reporting deaths, I'm not in a position to judge.
Well, I think we just have to rely on the World Health Organization, whether it's totally accurate or not. It is what it is, and what we need to be concerned about is what's going on here in Dane County and in the state of Wisconsin and in the United States right now.
I think probably the more important question is, what are our thoughts on the reliability of COVID-19 data from the US?
Exactly.
And
yes.
Of course, that varies from jurisdiction to jurisdiction. It varies by what part you're looking at. The real problem is it's so much of it is fragmented, that the CDC leadership we're used to seeing hasn't been out there as much as we should. So it wasn't until August, I believe, that all states were collecting data on race. And then we have the private-public systems where things are collected differently and stored differently that represent some real challenges. So that's one of the important things. Hopefully we've learned from the pandemic that we can begin to improve upon as we emerge from the emergency and start doing a real autopsy of what we've done right, what we've done wrong.
Well, in the final question, I think that a lot of this was answered in one of the slides that you showed, but maybe we could speak just briefly about the AstraZeneca pausing, and is there an estimate for when the vaccine might be coming for the public, and who will they give it to first? You addressed who will they give it to first.
I'll just say again, most of the quote estimates are generalizations because we don't know what's going to happen. We don't know the results yet. And so what's more important is that we follow the science, follow the administrative procedures, follow the safety protocols. When we do those right, we'll have a vaccine that works, because it's more important that the public, it's just as important that the public has a confidence in what's there as it is that we have a vaccine. So I can't give any accurate date when it's going to show up. Again, I think it's amazing that we've got so many talented scientists coming up with new ways of thinking about vaccines, new technologies, pushing things forward at an unbelievable pace. Where how many years past HIV, there's still no vaccine for HIV. Most vaccines have taken 4, 10 years or more to develop. So just to think that we might have something from those 123 plus candidates sometime next year is almost a miracle. Let's hope the work continues apace, that it continues carefully and safely, apolitically, and that some candidates emerge and that they're safe and effective and people have confidence in them.
Well, I will turn this back to you. Thank you.
Thank you, everybody, for joining us today. I just have the couple of questions to help us with a quick evaluation before you go. Looks like we've still got about 49 here, so I'm going to deploy that real quickly now. I want to thank you for your time. We spent almost 2 hours at it. I think we could probably spend another 2 hours tomorrow and 2 hours after that. The news, it seems like all the news is COVID news. All the podcasts are COVID podcasts. And that's just the environment we're in with this emergency. So here's the survey. I'm going to send you back to your phones to answer those 2 questions. That will help us figure out how good a job we did today and whether we could do something, might do something like this again. So that's, if you guys would fill those 2 questions out, you all see them there? Go to the polls, right? So just give a rating, 1 to 5 stars, and in a word, tell us what you thought about today's event. We'll see one more word cloud. And again, thank you for coming. Thank you for Plato for the Zoom sponsorship. We made it work fairly smoothly on a technical standpoint, so that's great. I think, have all come a long way with these virtual tools, and it's amazing that we have these capabilities and can pull something like this off.